afterload. The problem with the pump cannot get the blood out. Mainly this one, you see, sometimes you have the shock because of vasodilation. In the problem the problem in the pumps, what are the causes? Okay, anaphylactic. Okay. So all the anaphylactic septic shock. What does these two shock causing? What does they cause? How is it cause shock? Yes. So their mechanism are the same. So we call it as a vasodilatory. Okay. So it's under which your septic shock, anaphylactic shock, and one more is, anyone have you done auto before? What are the shock in the orthopedic? Neurogenic, yes. Neurogenic shock. Okay, these things are the problem in the autonomic. Mainly it's neurogenic because of autonomic dysfunction. You want to constrict but it vasodilate. So the another two problem is in the myocardial contractility, which is your cardiogenic shock. Cardiogenic shock. And then one more is obstructive shock. You have to remember there's another thing called obstructive shock. You mainly classify into these four categories will do. Okay, cardiogenic, what are the causes of cardiogenic? MI, heart failure, what else? Arrhythmia, yes. So technically it's all the heart problem. How about the obstructive? Yes, you mentioned pneumothorax. So it's problem in the lung. Technically, you have the myocardial contractility issue, anything pathology in the chest. Either you can have the problem in the lung. So the tension pneumothorax can compress, so your heart becomes restricted. So tension pneumothorax. Any more? TE, yes. Cardiac tamponade will be under the cardiogenic. Yes. So that's why. So when you understand this thing, basically in these two categories, in the problem in the myocardial contractility, the fluid doesn't work so well on this part. Remember, you see all these things, you cannot give too much fluid, right? You're going to worsen it. Because you know that there is no problem in the preload and the afterload. Okay, even in the afterload, you will see that there are some cases that doesn't need a fluid. So technically, what I'm trying to say is, you see, for you to pick up a type of shock, you have to examine the patient. Seriously, you have to examine. So I hope you all. So hypovolemic is either because of the blood loss or fluid loss, whether in the burn. And in surgical patient, you most common loss after the trauma. After the trauma, I'm leaving what else? GI loss, which is your vomiting or diarrhea. So that's what you always encounter. You see a lot, right? You have a lot. PGU, appendix, pancreatitis, all these things. Mainly they are losing fluid. They don't lose blood. Okay. So in surgical, you might encounter mostly is either the so this is a hemorrhagic, or we classify hemorrhagic and non-hemorrhagic. Okay. This one may sometimes mostly go to trauma ICU lah. Okay. This sometimes go to these two. Maybe you see in the general ward. Okay. So I hope it's easier for you to link all these things together. Then So sometimes you see when all these problems happen, your stroke volume will be altered. So that's why your body will try to compensate by tachycardia, right? Okay. So now how many types of shock that you know of? The hemorrhagic shock can form. How to differentiate first and second? What are the particular features? Just tell me that word, then I know you how to differentiate first and second. Heart rate, okay. So first and second, the first all parameter is almost normal. So it will be tachycardia in the second. Second and third, how you differentiate? Hypotension. So this is trying to tell you that don't wait until patient below, then you inform. Any patient tachycardia, you better inform. And in surgical patient, you can simply, you always think it's either is a patient is hypovolemic. You can safely assume patient is hypovolemic until proven otherwise. But you don't bring this in medical. Medical is opposite. Medical is mainly overload until proven otherwise. Okay? So you see in surgical patient, 9 out of 10 will be MDN. Right? Then for whatever reason, either it's an abscess, you want to post for op, our patient is bleeding, we plan for scope. So most of the patient is ongoing, losing the fluid. Okay, so that's why your examination when you assess the patient who is unwell in the ward, you try to exclude heart problem. Your aim is try to exclude the heart. The first thing you have to exclude the heart. Make sure that it's not MI. Make sure that it's not MI. So if the patient tacky, my advice is after the tacky, you assess the patient and you decide whether you want to give a fluid challenge or not. If patient show any sign of tissue perfusion, then you can simply give a fluid and you expect them to respond. If they don't respond and it worsens, then you auscultate the lung. Make sure that it's not APO. Okay? So, okay. You can show your table of the shock again, the shock, the four stuff. Okay, don't show us. Okay, grade 1 is how many percent of the loss? How many percent of blood loss? Huh? Okay, how about the grade 2? 50. Okay, grade 3? No, percentage. Your percentage of blood loss. So don't try to remember the volume, rather remember the percentage. So who can tell me 1, 2, 3, 4? One shot demonstrate. Because she showed everything. I just want to see how much can recall. I only try to highlight the important point because you won't be able to remember everything in the table. Okay. Anyone play tennis or not? Anyone you know how to play tennis? How is the marking in the tennis? You hit. Okay, let's say you hit. Okay. The second point is how much? 30. The third point is 40. The tennis court loop is 15, 30, 40. So you remember for your shot, less than 15 is grade 1. 15 to 30 is grade 2. 30 to 40 is grade 3. More than that is 4. Easier, right? No need to struggle. That's how I always remember the things. You try to simplify the things. Otherwise, it's too heavy for you. Now you can show the table. Okay. Okay. This only trying to tell you all these things you have to put in your assessment. But nowadays in the latest trauma guideline, I think this one may be taken from the 9th edition. In the 10th edition, they added one more parameter. Anyone has idea why I added parameter? That sometimes you need to talk to NS one. Sometimes you need to go to 8U or 8S. A test that you need to spoke to NS, or sometimes you can send to a lab which takes some time. ABG, yes. What parameter in the ABG you want to see? No, base assess. So there's another thing is which is the base assess. Okay, so 1, 2, 3, 4. You look at the base assess. Okay, what's the normal base assess that you know of? Plus or minus 2. Plus or minus 2. So you can accept 2 to minus 2. So understanding this, the 1 is always normal. So it's 0 to minus 2. So this one is minus 2 to minus 6. This one is minus 6 to minus 10. Okay? But that's this one, and in short, remember the grade 4 is 2 digit. You cannot have 2. You know the base deficit is too much means patient is very acidotic lah. You understand or not? It reflects the more and more acidotic. So that's why in the grading of shock, in the class of shock, this one is an additional. That's why there is a value. In the previously you want to argue with NS, then it might be difficult. So you can justify that you want to look at the base assess to assess your response to fluid saturation. Okay, about the lactate, I know sometimes our always ask for lactate lah. Okay, so there is always a role you want to look for tissue. Okay, lactate is a marker of tissue hypoperfusion. So what your colleague has said is, if your initial lactate is high, how you want to know is ischemia or dehydration? You try a fluid challenge. Then after fluid challenge, your lactate should be coming down. Okay, so now let me. Okay. You go to your ABCDE. Okay. ABCDE. Okay, this one. Okay, this one is what you learn in the trauma. Technically, in the ward you can use. My advice is, when you all have any patient with any complaint, okay, I remember any patient complaint, fever, chest pain, SOB, okay. Let's say the nurse tell you patient has BP, heart rate 120, patient BP will be lowish, or patient will be drowsy. These are the common complaints you will encounter. Remember, always go back to this, but you don't need to think about the C spine. So I'm trying to tell you, you still go back to ABCD. You still have to secure the A first. Even though the BP is, let's say, is 1960, but you look at the ABCDE, and okay, this one is mainly for trauma. I'm trying to tell you the algorithm is, any complaint, first thing you do, you check the 5 vital signs. You check the 4 vital signs. The fifth one, the pain, no need the pain score. When patient is a bit unwell, pain score is a bit difficult to access unless patient complain of pain. You understand not? Let's say patient complain of headache, okay, or patient complain of chest pain. Patient complain of chest pain. You still go back to the 4 vital signs: the BP, heart rate, respiratory rate, and temperature. And the fifth thing I need to remember: check the sugar, check the hypo count. Okay, don't forget, because a lot of times patient can simply just because of the hypoglycemia, or patient may be hyperglycemic, then patient can have a acidotic bleeding. You mean patient SOB. Then you check the CPS may be 20. Maybe patient admitted for good access or liver access or carbuncle. Remember, especially those patients who come with the infections, you have to be careful. I said, now this 5 things you tell. So if you report MO, tell this 5 things first. Tell 5 things. Doctor, patient complain this. I check this 4 vital sign. Okay, then we get this 5 vital sign. I would say 4 vital sign and 1 bedside test. Okay. Another thing is you don't have to tell all. If you are very some of you who are junior, you tell all the 5 figures. If you are more comfortable enough, just tell us anything which is abnormal. Or normal tensive, you just straight away tell normal tensive, but tachycardia, afebrile, not tachypneic, CBS is normal, your sugar is normal. That is the initial phase only. And then, only then you go to the ABCDE. Okay, generally, if any patient potentially unwell, let's say for respiratory or chest pain, it is safe for you to give oxygen therapy without informing FO. You can give first, then you let the FO know. Let's say patient come in appendix, example, haven't post for off. Okay, the FO takes the purple the appendix. That's why patient complain SOB. It can be because of the diaphragmatic splinting, the abdomen distension, or whatever it is, you haven't opened the abdomen. So look, that is something you cannot do immediately. What you can do is, you can give oxygen therapy. Either you want to give nasal swab, you want to give face mask. That's one thing. Second thing is, if the patient is hypotensive or tachycardia, you always give the fluid first. Understand not? Okay. So those of you who have encountered, what fluid you want to give? What fluid you want to give? Let's say, I go sometimes to tell you what fluid to give, or just say, okay, run fluid only. So what fluid you want to give? Huh? So based on your encounter, what your MO always ask you to run? Okay, Hartmann or normal size. So, but because okay, based on understanding, which one will be your preferred choice? Okay, normal saline. So sometimes the on-call MO asks you all to give normal size. Is it? Okay. There's no right and wrong. There's no right and wrong, but preferably in surgical patient, sometimes the Hartmann will be a better choice. But either way, it's okay. Does anyone ask to give D5 at the volume before? D5. Dextrose? No, Okay. Do you know why? Why dextrose is not a fluid resuscitation?
Hypoglycemic.
Okay. Can you hold a seminar on the fluid electrolyte or not? Okay. Already got or not yet? Or coming? Coming up. So someone will be presenting it, someone will be presenting it. Is it, or is it in your checklist?
Can
Tak ada
ada
kan?
tapi boleh tambah nanti.
Okay. Because sometimes the things are overlap, so I hope you also mind I explain a bit lah, Okay, but never, I will go back to that later. So after you check, just make sure that, so one simple thing you can give for every, you just at least you can look at patient for any swallow, or maybe patient is choking, or maybe foreign body, or maybe aspirated. For example, patient has been distended, so they have difficulty swallowing, so suddenly choke on the sputum or what. So that one you can listen the swallow. So then sometimes you look, when you go to a breathing part, you auscultate to look for any crepitations or bronchi. Okay, if crepitation, you can give net 3% saline, hypertonic. Okay, if you got bronchi, which is a bronchospasm, you can at least give the Ventolin, the salbutamol, the Ventolin plus normal saline, which is VNet. Is it Ventolin here? They use the word Ventolin or salbutamol? Salbutamol. Okay. They all use net salbutamol lah. Consider used to we use Ventolin. So it's a salbutamol plus saline. That one normal saline, 0.9%. The 3% saline. The 3% saline is just to the 3% saline usually be better for those who had the crepitations. Okay. So that's why at least you think. So when you want to inform, you tell us the basic examination findings. Okay, you tell us the basic vital sign, your clinical examination findings, and then what is your okay, let's repeat patient tachycardia. You can just say okay, if you are afraid to give fluid, you let us know. I hope you all suggest, when you all inform us, you all suggest, you understand or not? You all suggest. Say I think I want to give face mask and I want to run one time over how many, 30 minutes or 1 hour.